Hello, everybody. Greetings from IGCP Group and Heart Care Foundation of India, and also from our supporter of this CME, which is Sun Pharma. I am Dr. K.K. Agarwal, President of Heart Care Foundation of India. Today, we are going to talk about an important subject, and we are talking about redefining management of diabetes by a group of drugs called SGLT2 inhibitors. For cardiologists, diabetologists, endocrinologists, it's easier to know this molecule. But I want this molecule to be known to everybody, every doctor in the country, whether they are orthopedician or diabetic, or they are surgeons or gynecologists. And the drug in focus will be Dapagliflozin. So I will name it as Dapper. So the word, how will we remember Dapper for those who are non-physicians? The word D starts for Dapper, D for diabetes. So therefore, this is a primary drug for diabetes. How does it act? Sg means sugar, L means lowers. It lowers blood sugar through the urine. And when it comes to T and 2, T means total, 2 means number numerical 2. It has two more actions apart from lowering the blood sugar, and that is in heart failure and in CKD, even without diabetes. So SGL, it lowers sugar. Apart from that, it has two more actions, and that is it is helpful in heart failure, and it is also helpful in CKD. CKD would mean, I'm not talking about microalbumin positive, I'm talking about macroalbuminuria, which is severely albumin excretion in the urine. Then I was thinking how to remember these words, how does it act? So I was looking at the brand name of Sun Pharma, who is initiating this discussion and calling thousands of doctors in the country. So I thought their brand to be Oxra, O-X-R-A. R means renal, that means in CKD, or also means reduced ejection fraction. So if you have a heart failure with reduced ejection fraction, there is A. It ends with the word A, which indicates it is atherosclerosis. So atherosclerotic diabetes also, there is a role of dapagliflozin. Then I was thinking, what does OX represents? OX basically represents, apart from lowering its sugar, it also has an action of reactive oxygen species as an antioxidant, because it causes reduction in inflammation. That means IL-1 beta, IL-6 and TNF blocker. That's how I thought all the doctors in the country can remember who are not physicians. Let me introduce my faculty today. I have Dr. Sujay Ghosh. He is the professor of Department of Endocrinology, Institute of Postgraduate Medical Education and Research from Calcutta. He is going to talk about SGLT2 inhibitors in diabetes and across cardiorenal continuum. Then I have with me Dr. Prakash Kumar Hazra. He is the head of Department of Cardiology, Director of Cardiac Cath Laboratory, Emory Hospital in Kolkata. He is going to talk about the small r, and that is heart failure with reduced ejection fraction. And I also have with me Dr. Manisha Sahai. She is professor and head Department of Nephrology, Osmania Medical College, Hyderabad. She is the vice president, Indian Society of Nephrology. Obviously, she is going to talk about the next T, and that is the role of SGLT2 inhibitors in chronic kidney disease. So today, our subject will be difficult subjects. Uncontrolled diabetes. Do I go to insulin or do I have a choice? Second, I know how to manage a patient with a albumin of less than 30, more than 30 and less than 300. I know I have ACE inhibitors and AR blockers, but if my urinary albumin is more than 300, severe proteinuria, how do I handle? And if I have a ejection fraction which is lower than 40%, reduced ejection fraction, can I improve ejection fraction? Can I improve longevity? Can I prevent sudden death? With this in mind, I'll ask each speaker to speak for around 12 to 15 minutes, and then we will have a discussion. So the first speaker will be Dr. Sujay Ghosh on diabetes and across cardiorenal continuum. Dr. Ghosh.
Good evening, friends and colleagues, wherever you are in India. Thank you, Dr. Agarwal, for that kind introduction about today's program. I shall try to be as brief as possible as requested, and I hope my slides are now visible.
No, you will have to, yes.
Yeah.
Go ahead.
So I have been asked to speak on the role of sodium glucose transporter 2 inhibitors in diabetes and across cardiovascular continuum. Now, because we are talking about a very, very different group of drugs than compared to, what many people have been knowing, particularly those who are not physicians, those who are not diabetologists or endocrinologists. Just to give a very quick recap, is that in the kidney, we have the glomerulus, where there is a process of filtration. The glomerular filtrate contains a lot of things, including sodium and glucose. In the proximal convoluted tubule, predominantly, this sodium and glucose is reabsorbed through certain transporters, which are called sodium glucose transporters. There are two kinds which we usually talk about, type 1 and type 2. This is a group of drugs that will block the reabsorption of sodium and glucose in the proximal convoluted tubule, resulting in loss of glucose through the urine. So this loss of glucose through the urine is expected to reduce the blood glucose level, irrespective of any action on insulin per se. And this loss of glucose will lower blood glucose in patients with type 2 diabetes. And this calorie loss is expected to reduce body weight in patients with type 2 diabetes. And when this group of drugs first came onto the market, like described by our honorable chairperson, that this group of drugs became primarily used to treat hyperglycemia in diabetes. So that's where the positioning of the molecule was in terms of management of diabetes. Like the next two speakers are going to talk about, that this group of drugs has actually now gone beyond diabetes management, in the management of heart failure and in the management of chronic kidney disease, irrespective of whether you have diabetes or you don't have diabetes. So I've already told you that this glucose lowering effect of SGLT2 independent of insulin. And today my subsequent speakers are going to talk about the benefits in heart failure and chronic kidney disease, which are independent of the glucose lowering effect of SGLT2 inhibitors. So we've gone a step beyond diabetes management in terms of metabolic benefits and organ protective benefits of this class of molecules. The cardiorenal protection is independent of the glucose lowering effect of SGLT2s. Now, for a lot of you are already aware, and most of my talk might be repetitive, but just to recap, that whenever a new drug is marketed for diabetes, it has to undergo a cardiovascular outcome trial. And the first of the cardiovascular outcome trials of this group of drugs was the EMPEREG trial in 2015, which was done predominantly to show that the drug is safe. But the surprise came that this drug was not only safe, but it was actually reducing cardiovascular deaths, cardiovascular events, and all-cause mortality in patients with type 2 diabetes who already had established cardiovascular disease. This was followed up with the second drug, that is Dapagliflozin, in the CANVAS program, which showed that the composite of cardiovascular events was reduced and the composite of heart failure, hospitalization, and cardiovascular death was reduced. And the renal benefits was predominantly exploratory in nature, but suggested that there might be some renal benefits as well. This was followed up by the cardiovascular outcome trial of Dapagliflozin, that is the declared TIMI trial, which showed that this trial included not only people who had established cardiovascular disease, but also individuals who had risk factors associated with possibility of cardiovascular disease, that there was a reduction of the co-primary endpoint, which was composite of CV death and hospitalization due to heart failure. And again, like the previous two trials, had exploratory data regarding renal outcomes to suggest that this might be beneficial for kidney purposes as well. Following that, in 2019, a trial was published, the Credence Trial, which is a renal outcome trial of Dapagliflozin, which clearly showed that in patients with type 2 diabetes with some kind of kidney problem, they had benefits in terms of renal outcomes were concerned with the trial. So I've just tried to summarize in about 4 slides the results of 4 major trials of these 3 gliflozins to show that they are good as far as the heart is concerned and they are good as far as the kidneys is concerned. With regards to the other studies, that is the Dapa-HF and the Dapa-Ckd, my subsequent speakers are going to talk about that. So just to recap, what started off as a glucose-lowering agent, after EMPA-REG and CANVAS, we realized this was a drug which was going to protect the heart in terms of mortality and cardiovascular event. After the declared TIMI, and also from the Credence as well, we know that it's going to be good for heart failure as well. And this is now a paradigm shift in the management of diabetes. Number one, in patients with diabetes, we are now convinced that this group of drugs are good for the heart and the kidney. And my subsequent speakers will show that even in individuals without diabetes, it's good for the heart and the kidney. So this is going to become more of a drug for the cardiological benefits and the renal benefits, and not necessarily remain as an anti-diabetic agent. So the SGLT2 inhibitors in heart failure, that's the Dapa-Ckd, the Dapa-HF trial, showed that there is benefit in terms of heart failure even in patients without diabetes or in patients with diabetes over and above what the current standard of care is. And it shows that it's able to prevent heart failure, those with heart failure with reduced ejection fraction, whether you have diabetes or no diabetes. So this is the second paradigm shift that's happened, that it's improved management of patient with reduced ejection fraction heart failure, whether you have diabetes or whether you don't have diabetes. So it's not surprising that the European Journal of Heart Failure in 2018 has quoted some of the studies which show that there are, the EMPA-REG MRI finding studies to show that there is modulation and remodeling of the heart with empagliflozin. And all of these we've got to think of has to be counterbalanced with the possible risk of increased risk of genital infections, diabetic ketoacidosis, and hypovolemia. So this particular molecule made by today's sponsors, that is, marketed by today's sponsors, has been used in type 2 diabetes. The declared TIMI gave us evidence that it is useful as far as atherosclerotic cardiovascular disease is concerned. The Dapa-HF study tells us that it's beneficial for heart failure. The Dapa-Ckd tells us that it's beneficial for the kidney disease. And whether you have ASC, even if you don't have ASCVD, heart failure, or CKD, the declared TIMI tells us that there are benefits. And that has actually led to several changes in guidelines. The European Society of Cardiology now recommends SGLT2 to lower the risk of heart failure hospitalization in patients with diabetes. The American Diabetes Association has stated that this group of drugs are great when it comes to management of diabetes, particularly those associated with atherosclerotic cardiovascular disease, those having multiple atherosclerotic cardiovascular disease risk factors, those with heart failure, those with kidney disease, and those even at risk of any of these problems. We now know that there are several molecules in this class, And it's very difficult to actually differentiate one from the other. But as of now, like I said, the evidence is very good for even for dapagliflozin, particularly when it comes to renal outcome, along with heart failure data. There are trials going on in heart failure with preserved ejection fraction. Whether this group is going to have benefits there as well, we don't know. And we don't know what the long-time benefits is going to be very sustained. Because even in these short-term studies, the results seem to be dramatic. So cardiologists and nephrologists have often not used, but I think more and more cardiologists and nephrologists have picked up. At least the IMS data now suggests that cardiologists and nephrologists are perhaps prescribing the drugs even more than endocrinologists, which is good. But I still think there are gaps which need to be addressed. Cardiologists need to speak to diabetologists. Diabetologists need to help out cardiologists, because at the end of the day, it's the patient who is at the center of care. We need to help the patient out. A particular study looked at, the prevalence of cardiovascular disease in type 2 diabetes. Not surprising that almost 40% of the people with type 2 diabetes had coronary artery disease. And it's a pretty big study which shows that among 30% of type 2 diabetes patients with prevalent cardiovascular disease, consultation rate with cardiologists was 4 times than with an endocrinologist. Whereas if the patient had heart failure, he was more likely to go to a cardiologist. So we need to work as a team. And cardiologists should encourage also to prescribe SGLT2 inhibitor, which has already happened. And in future, this is going to be a cardiovascular drug and a nephrologist's drug rather than, being cornered as an anti-diabetic agent. And like I've said, the SGLT2 now covers an entire spectrum where you're talking about the heart failure continuum, where you had declared TIMI for prevention, Dapper heart failure for prevention and treatment. In terms of the renal outcome, the declared TIMI as well as the Dapper Ckd. And if you look at primary prevention, you have declared partly from Canvas. For secondary prevention, you have the EMPEREG study. So all across the spectrum, you have evidence from the various SGLT2 inhibitors that this group of drugs, which have been predominantly being used all along as anti-diabetic agents, are great drugs as far as cardiovascular disease and heart failure is concerned, and renal disease. So early initiation of SGLT2 inhibitors in diabetes is going to be the way forward, that in addition to microvascular disease complication like kidney disease, retinopathy and neuropathy, macrovascular disease benefits will be there. Heart failure benefits is going to be there with this group of drugs. And early initiation is what we want of this particular class of drugs. CV outcome trials I have already talked about. So the CV outcome data suggests that all of these drugs are pretty good when used either in individuals at low risk or high risk of heart disease or renal disease. So I shall stop there and hand over to my respected chairperson. Thank you very much.
Thank you, Sujay, for a beautiful, simple, easy to understand presentation. So therefore, you cannot think of diabetes without DAPA. I am remembering the word DAPA is easy to remember. D for diabetes, D for DAPA. That's the easy way of remembering. Then with that, you can come back to other brands which are also available. So one thing is clear, that if you are a diabetic, the drug may become indispensable because of associated macrovascular and microvascular disease. It is used in atherosclerosis. In cardiology, we say diabetes is CAD equivalent. And when it comes to kidney and heart failure, both of them are common in diabetics. Therefore, this drug ultimately will become a must drug. But then the thing comes is, when it is going to cause increased sugar in the urinary tract, people are concerned about the infection, the genital infection and the urinary infection. So there came a role of this drug in non-diabetics, where even if the blood sugar is slightly more in the urinary tract, it may not be of that much concern. Therefore, the role came is, how about the DAPA group of drugs in heart failure management with reduced ejection fraction independent of diabetes? So Joy has talked about in diabetes. Now we are talking about independent of diabetes also, in great detail about Dapper heart failure trial. So I present to you Dr. P.K. Hazra, who will talk about the role of Dapagliflozin in the management of heart failure with reduced ejection fraction. Remember, there are two types. Ejection fraction is indirect functioning of the heart. When we say reduced ejection fraction, means systolic function is gone. When we say preserved ejection fraction, it is more like a diastolic failure. You have systolic dysfunction, systolic failure, and you have diastolic dysfunction and a diastolic failure. Today, we are going to talk about reduced ejection fraction, usually, which is clinically associated with a systolic heart failure. Over to you, Dr. Haza.
Thank you, sir. And heart failure, today in 2021 has become very important. And now we have many drugs, and these drugs are used all across the spectrum of heart failure. Again, this is an arbitrary classifications based on ejection fractions. But with the introduction of SGLT2, perhaps these classifications should not be there. We treat all heart failure with the same 4 classes of drugs: ARNI, beta blocker, the MRA, and SGLT2. But you get the most benefit if you have
Your slides are not coming. You have to close the slide, then open the slide, and then share. No. Okay. You have to first open your slides. You have to close this window. First, open your slide.
Share.
And then share. Then you share, and then choose.
Okay. So application window?
Yes. And then choose the slide which is already open.
Okay, let's do that. Can you see my slides now?
Not yes. No, you have still done the same mistake. So what you should do is first you close the slides.
Okay.
First you close the slide, and now open your slide first. Open the slide.
Okay, let me just.
Then go to, once your slides are open, have the first slide open. First slide open.
Okay, just a minute, sir.
No, it's not coming. Ritu, you help him out.
Sir, can I share the slides?
Can you see?
Yes. Yes. Now go ahead. Go ahead.
Okay, so heart failure, this classification is again arbitrary based on some certain numbers, but I feel all the heart failure should be treated in 2001 in the similar fashions: ARNI, beta blocker, MRA, and SGLT2. And there is a lot of unmet needs. Your therapy should start at the very early stage of heart failure, those who are at risk, those who are in clinical heart failure, those who are in advanced heart failure. In spite of having knowledge, the penetration of this foundational 4 fabulous therapy is very, very, very low in our society because lack of knowledge, socioeconomic issue, the price factors, availability, and attractive solutions in rural areas. So the mortality has increased and will continue to increase. Now, if you have this kind of patients who is a chronic stable angina, past history of CABG, past history of angioplasty, you have a return of patients from an angioplasty by a cardiologist will treat your coronary artery, but that does not prolong life anymore in stable coronary artery disease, neither CABG nor stent. So you have to fall back on his medical therapy, which is a polypharmacy nowadays. We have to think about rivaroxaban, the compass way, You have to think about statin, PCSK9. You have to change the metabolic milieu, the metabolic remodeling, the ejection fraction remodeling, cardiac remodeling, atherosclerotic remodeling, your ejection fraction on SGLT2. You have to take care of the kidney, your myocardium, your mitochondria, your brain, your uric acid, your endothelium, so on and so forth. That is possible by only one drug, that is SGLT2. So this is the story of a new class of drug. Cardiologists must know in post-PCI, post-MI, post-CVG, medically treated SES, CCS, chronic coronary syndrome, heart failure, CKD, ischemia trial-like patients. We had this Saregama Padanisa. The drug one came in 2015, which prevents cardiovascular death, prevents heart failure. Then in 2017, the drug two came, second class came, or second drug came, which prevents stroke, prevents heart failure. Again in 2018, the drug 3 came, prevents heart failure. This repeated in 2019, delay cardiovascular death and treats heart failure. Drug 2 was again tested in 2019, delays cardiovascular death, delay renal death. Drug 4, 2020, prevents heart failure. Again, the drug 1 came in 2020 with different subsets, different kind of patients treating heart failure. Drug 3 came in, dealing renal death. Drug 5 in acute heart failure, acute decompensated heart failure in 2020, which has been discussed recently in TCT. And we have a drug again, and drug 1 here has come back with 2020, which improves ejection fraction. For the first time in cardiology, we came to know that like ARBs or ARNI or beta blocker or a CRT device, you have an anti-diabetic drug which can improve your ejection fraction by 6% and can prevent remodeling. These are all orally anti-diabetic drug. There is no prick, no pain, and you'll be surprised to know these are one class of drug that is called SGLT2, dapagliflozin, dapagliflozins, empagliflozins, canagliflozins, artegliflozins, sotagliflozins. So this Saragama Padanisa of anti-diabetic drug has become a game changer, and all must should practice this kind of drug therapy in all heart failure. So we have a drug in heart failure at risk, that means smoker, those who are hypertensive, those who are living hypertrophy, those who have very bad family history of renal death, cardiovascular death. You have many trials to support that. Empire, Canvas, Declare, Credence, Barton, Dapper, Ckd. You have a drug for risk with structural heart disease, like you have a stent, you have a CVG, and the classical heart failure with symptoms, irrespective of the ejection fraction. If you have ejection fraction towards the lower side, you will get better benefit, but definitely you will also get additional benefit because the lower ejection fraction, you don't bother about their weight, but with in normal ejection fraction, these people have atrial fibrillations, comorbidities, weight, obesity, uric acid, hypertension. They have atrial fibrillations and sleep apnea, etc., etc. You have a dapagliflozin, sotagliflozins, empagliflozins. In advanced heart failure, we also talk about these drugs because this drug does not cause hypertension. So SGLT2 inhibits heart failure, whether you have diabetes or non-diabetes, and more so in the diabetic. As I mentioned, I'm repetitive here, that this CVOT trial has proved beyond any doubt that if you use this drug very early in your life, it will prevent death, and it came from the Declare TV and other trials. So these trials has proved that if you have atherosclerotic cardiovascular disease, do not have atherosclerotic cardiovascular disease, if you have diabetes, no diabetes, CKD, no CKD, up to 25 ml, you up to ejection fractions of 55%. So it is HEPREP, MBREP, all in all subgroups it works. And there is a potential mechanism. Don't think it is a diuretic. Initially may work as a diuretic, so be careful about the diuretic use. So it does reduce your volume status. It can cause dehydrations. Interstitial volume is reduced more than intravascular. The sodium hydrogen exchange inhibitor, modulation of autophagy. That this drug is like, hey, you have the housemaid. The housemaid comes in the morning and she cleans the house and keeps the house beautiful. So this drug actually keeps your bugs or your potential toxins in the heart, in the kidney, the hypoxia, the effect of this kind of metabolic toxicity in your heart removes, and it can prevent the cardiac death. And it is simple, once in a day, does not need any titrations, and it is a super fuel kind of thing, and it improves renal death and cardiovascular death. This is the trial, and this is a beautiful trial which says that if you start this drug very early in heart failure, with or without diabetes, you prevent one death out of 21 patients with a huge reductions of hazards, and very good p-value, and this separation is very early. Like unlike any cardiovascular drugs which does not give benefit at 4 to 6 weeks, these drugs on the very first day you get some hemodynamic effect, and you continue to get maximum benefit if you use for a longer period of time. So at 4 to 6 weeks, this drug starts showering his choicest blessings on heart failure and the prevention of death, worsening of heart failure, repeat hospitalizations, cardiovascular hospitalizations, all-cause death, all-cause mortality, and it is universally found. And with this may be a class effect with dapagliflozin, 10 milligram per day. It doesn't have much side effects. You be careful about the sick day management. You be careful about your hydrations with other potential drugs which can cause your renal dysfunction. You should not use in sepsis, irrespective of the diabetes, renal status, age, ejection fraction, background therapy, anti-proBNP levels. As I said, it improves quality of life, adds lives to life. So this drug, if you combine with my drug, like cardiovascular drug, RNA beta aldosterone, you get fabulous NNT. The best NNT in medical history is 1. So that means if you treat malignant malaria with quinine and if you save one life, the best NNT is 1. You save one, you prescribe one drug, you save one life. So similarly, NNH, that means number needed to do harm, is also 1. You treat tuberculosis with malignant malaria quinine drug, you kill this patient, that NNT is also 1. So you one drug, one kill. So these drugs, 4 drugs, if you combine, you prevent 1 death out of 4 patients, relative risk reduction 73%. And if you use at 55 years, and even if he has missed the bus on these 4 drugs, your mortality, 2-year mortality is reduced from 35% to 25%, 16 to 11%, ultimately less than 10% single digit. As long as he lives, as long as he uses, it gives 5.5 extra life and life to years. 8.3 years event-free survival and delaying the cardiovascular death. Death can never be stopped, but it can be delayed. If you use at 60-year male, 4 drugs, fabulous drugs, 6.3 years extra life and 7.5 years event-free survival, and it delays cardiovascular death. And it has got certain NNTs which is better than RNA. You have this pacemaker is 23, your SGLT2 is just 21, is very close by. And you don't have to bother about this line. You can come here. This SGLT2 can come here. It can become a 4th drug. Can become first drug. So with this, let me present my thought today. There is no more step care. You can start here with MRA, then go RNA. You can go to SGLT2 at the very beginning. It's not a step care anymore. It is a circle. All 5 drugs, including diuretics, at some point of time you have to use, but all 4 drugs at the very onset of heart failure, at the very early diagnosis of heart failure, recurrent heart failure, it should be combined if they can afford it, if your hemodynamics parameter suits it. So there are 5 pillars, which includes ivabradine also, sometimes a diuretic. But if you do not prescribe this drug, if you do not understand this drug, if you delay this drug, that will cause more deaths. So ladies and gentlemen, it's not one day. Let it be day 1. If you do not prescribe, my friend will prescribe. If my friend do not prescribe, then his enemy will prescribe. If both decline patients, the patients will buy it from the store and they will eat it and they will take it. So it's not one day or day 1, which I mean, it's not no more one day. It has to be day 1 drug, and you decide how do you treat your heart failure with reduced ejection fractions with anti-diabetic drug. Thank you very much.
End, and he has added D for Dapper, D for diabetes, and now he has added D for day 1. That you can also consider it using it on day 1. So it's a triple D. Up till now it was 2 Ds. Now he's talking about that in echo you have 3D to remember the 3D word. Now before we discuss, let me now go back to our third speaker, Manisha. And basically she's going to talk about CKD. Now, if we can prevent progression of CKD, now everybody goes from one place to another. They go to homeopath, Ayurveda, and everybody is concerned, can I stop my progression? People say if you have a albumin in the kidney of 330 to 300, you have microalbuminuria, now called as moderate albuminuria. And people say, okay, ACE2 AR blocker, I can restrict them. But up till now, there was no specific treatment when you have overt albuminuria. We still talk about trying diltiazem as a cardiologist in such cases. But yes, now we have a drug which can take care of macroalbuminuria and stop the progression of CKD. I always say CKD, I classify them less than 30 and more than 60. I said more than 60, even a GP can handle under consultation with a physician. 30 to 60, a physician can handle under consultation with a nephro, and less than 30, only nephro should handle. So this drug for physicians and GPs, let's listen to Manisha, what she has to say as far as Dapa is concerned and stopping the progression of CKD in a patient with or without diabetes. Over to you, Manisha.
Thank you very much, sir. It's an honor to be here amongst all very well-known people. So I'll be talking about the chronic kidney disease part and its relevance to SGLT2. We all know, as sir has already pointed out, CKD is a huge burden. And why do we say that? In the world, it impacts 1 in 10 people. That's a huge number, 10% of the world's population. And you can see that 5 million by 2030 will be on renal replacement therapy, dialysis or transplant. So this is just too much, 10% of the entire world's population. And the main cause of the CKD is diabetes. We know that 40% of all diabetics have CKD, and it may increase to 50% shortly. And look at the figures in India, 17% of our population has CKD, and most of it is diabetic CKD. And around 2 lakh people, they need dialysis every year in India. So we definitely need to do something to prevent this diabetic kidney disease. And apart from that, the kidney disease, it causes progression to dialysis, transplant, a life full of dialysis, but the patient also becomes at a high risk of cardiovascular death because CKD is an important risk factor for cardiovascular death as well. Treatment is available. We have dialysis and transplant, but look at the cost of treatment. Transplant is 5 to 6 lakhs. Dialysis is 30,000 per month. So huge burden. We have some treatment to prevent this progression, as Dr. Agarwal was pointing out. We have RAS blockades, inhibitors, and ARBs, but all the other drugs have been failures. So it was very dismal. We were not able to treat these patients who came to us with kidney disease. Now there is some hope in the form of SGLT2 inhibitors. As the previous speakers have also pointed out, we know they have a non-insulin dependent mechanism of action. And why the nephrologist is involved? Because here the loss of glucose is through the kidney. So they act on the kidney and cause loss of glucose, which brings down the blood sugar in simple terms. We all know that they act on the proximal tubule. The SGLT2 is the main one, which contributes to 90% of absorption. Now, how does this SGLT2 inhibition, it helps in preventing the progression of renal disease? Remember that renal disease progression occurs because of overwork, overfiltration. Whenever there is some loss of nephrons, the remaining kidney, as you can see in the third figure, keeps on working more and more, gets tired finally, and because of this hyperfiltration goes into chronic kidney disease, end-stage kidney disease. And this is what is blocked by SGLT2 inhibitors. You can see what do these drugs do. Whenever we have this filtration of sugar in a diabetic, most of this sugar is absorbed in the proximal tubule, as you can see in the figure, along with sodium. And as a result, less sodium is delivered to the distal tubule, macula densa. And as a result, macula densa tells the afferent arteriole, I'm not getting any sodium, you filter more sodium. And as a result, the afferent arteriole dilates and it brings more blood into the glomerulus. And what does this do? This causes hyperfiltration. And as I said, this causes injury. Hyperfiltration is bad. And this is exactly what is blocked by the SGLT2 inhibitors. So this is their main mechanism of action. That is, they reduce the intraglomerular pressure and the hyperfiltration. But this complicated cartoon shows that they have other actions as well. They act on the renal tubule. They are antioxidants. They decrease inflammation. They are antifibrotic. They are very good drugs. They bring down the renal work. So because of all these mechanisms, we call them cardioprotective. They reduce the blood pressure. They reduce the weight. They reduce inflammation, reduce renal work, reduce albuminuria, and they are really smart diuretics. So with this background, physiology seems good, that SGLT2 seems very beneficial. But what is the evidence? Do we have evidence? We have evidence from n number of trials. The first one was Canvas trial, followed by Canvas R trial, which focused on the renal outcomes. Then EMPA-REG trial, where the cardiovascular outcomes were primary, but renal outcomes were secondary. So all these three, you can see that they were not primary renal outcome trials. They were more focused on the cardiovascular outcomes. And you can see the green color means the renal patients in this had mild renal failure. Now you come to Credence. Credence, the red pattern shows that they had more renal failure. The GFR was up to 30. So this trial focused on Dapagliflozin. And then came the Dapper Ckd, the land-breaking, the path-breaking trial, Dapper Ckd, which was also in severe renal failure, in addition in diabetic as well as non-diabetic patients. So these are the important trials. Now looking at the Canvas trial, renal outcomes trial, you need not go through the whole thing, but you can see that these patients, 10,000 patients, huge number was there. You can see the Dapagliflozin and placebo, and you can see that the risk of increasing creatinine or end-stage kidney disease or renal mortality, GFR decline, this was much less in the Dapagliflozin group as compared to the placebo group. The albuminuria new onset was less in the Dapagliflozin group. Renal adverse events also were less in the Dapagliflozin group. So this showed Dapagliflozin is renoprotective. What about the EMPA-REG trial? This also was a primary CV outcome trial, but the renal outcomes were secondary. And here also it showed that Dapagliflozin also was good, that it reduced, you can see on the right side of the figure, the rate of GFR decline. It was less in the Dapagliflozin group as compared to the placebo group. So it had main cardiovascular benefits, which was the primary outcome, but nephrologists were happy because even the renal benefits were seen in this trial. So Canvas R showed the same thing. EMPA-REG also showed the same thing. Then came the Credence trial, and this we were a part of this Credence trial, and it was very important for the nephrologist because here the main outcomes were, the primary outcomes were the renal outcomes. And here again you can see that again as compared to placebo, Dapagliflozin, it reduced the composite of end-stage kidney disease, doubling of creatinine, renal or CV death. So this was very useful drug. And the secondary outcomes were cardiovascular outcomes, and they also showed benefit. So significant reduction in renal function decline in the Dapagliflozin group. Then we had some CVD real evidence that also showed that SGLT2, they reduce the fall in GFR and they improve the cardiovascular outcomes. This is real world data. So we had randomized control trials, the Canvas R, the EMPA-REG, and we had Credence. Subsequently, we had this real world evidence, which all showed the same thing: good for the heart, good for the kidney. So this was very clear that in type 2 diabetic patients, we had Sglt2 inhibitors, which were proven to be reno-safe, reno-benefit, as well as cardiovascular benefit. Why is Dapper Ckd so important? That's important because it deals with patients who are diabetics, as well as for the first time we have a trial which deals with CKD patients who are non-diabetic as well. And that is the beauty of this trial and this drug. So here again, we had patients who were more than 18 years, who had low GFR, who had albuminuria, who were already on ACE and ARBs, and still they had albuminuria, still they had a declining creatinine. And they were put on either Dapagliflozin or placebo. And the outcomes were primary renal outcomes and secondary, the cardiovascular outcomes and composite outcomes. And what did this trial show? Is it applicable all over the world? Yes. You can see in red, Indians are also there. 201 people in Dapper Ckd were from India. And you can see the beauty of this trial, that it includes diabetic kidney disease, but you can see a host of other kidney diseases as well. So you can use this anti-diabetic drug in non-diabetic kidney patients as well. And that's the beauty of this trial, which was shown for the first time with the Dapper Ckd trial. And you can see all down arrows, the renal endpoints, all 39% relative risk reduction in the rate of decline, ESKD, renal or CV death. 39% is a huge reduction. And It was shown that this reduction was seen irrespective of the level of GFR, whether the patient was diabetic, non-diabetic, whether the patient had albumin less than 1000, more than 1000, or whether the GFR was less than 45, more than 45. So this Dapper-Ckd showed that you use the drug at any level of GFR, any level of albuminuria beyond the 25 cutoff of GFR, you have benefits, definite renal benefit. Secondary outcomes, again, 44% relative risk reduction. Chronic dialysis, kidney transplant, or renal death, again 34% relative risk reduction. So remember, at least 30 to 40% renal risk reduction. Huge benefit. No other drug provides this much benefit. What about CV death or hospitalization for heart failure? Again, 30% reduction. Huge benefit again. All-cause mortality, 30% reduction. So it's very clear, Dapper-Ckd showed that there is a decline in renal endpoints, cardiovascular endpoints, composite endpoints, and all-cause mortality. There was another trial, Diamond trial, with the same molecule, Dapagliflozin, in Canada, Malaysia, and Netherlands. And what did this show? Again, the same, that there was a change in proteinuria in the Dapper group. The GFR changed with Dapper group to a better value. There was a reduction in body weight. The adverse effects in Dapper as well as placebo were similar. So no major side effects, no hypoglycemia, and no deaths. So we have Diamond trial and Dapper-Ckd trial. So now coming to the heart failure part of it. What about the heart failure, the Emperor-reduced trial? This has been dealt with the previous speaker. In this group also, why a nephrologist is talking about Emperor-reduced, you might think cardiologist has already covered it. I'm just talking about it because look at the renal group, the last one. There was 50% reduction in renal events, even in these people where Dapagliflozin or SGLT2 inhibitor was used for cardiovascular benefit. So you had benefit for the renal endpoints as well, even in Emperor-reduced trial. So the composite of Emperor-reduced and Dapper-Ckd, what does it tell us? That in all diabetic patients, as well as in non-diabetic patients, the SGLT2 inhibitor, especially the Dapper, which has been tested in both the groups, there is a significant cardiovascular benefit, significant renal benefit. So this point has to be remembered by all of us. These drugs are being underused. We should know when to use them rightly. These benefits occur even when the GFR is less than 30. So ladies and gentlemen, when should we use these drugs? All patients with diabetes who have or are at risk for ASCVD, yes, use SGLT2 definitely. If they have been on lifestyle modification, on metformin, on sulfonylurea, insulin, if this drug, the SGLT2, is not a part of the prescription, you are wrong. So any diabetic, whatever other drug you are using, if they have ASCVD, this drug should be a part of the prescription. Those diabetic patients who have renal disease, meaning albuminuria or low GFR, this drug should be a part of prescription. Many times the patient asks us that the sugar is well controlled, I'm on metformin, I'm on sulfonylurea. When we add this drug, they ask why, for what reason. If they have renal disease, you have to add this drug. And in case you need to reduce the dose of hypoglycemic agents, you should reduce the dose of other drug, but make sure that SGLT2 should be a part of the prescription. About non-diabetic kidney disease with CKD, with renal disease, again add this drug. And this specially holds true for Dapper, because with Dapper alone, we have evidence for non-diabetic kidney disease. And heart failure already, as has been alluded by my previous speakers, this drug has to be used in heart failure with reduced ejection fraction. Safety outcomes of Dapper-Ckd, quite safe, no major side effects. And we should know when not to use them, which we all know. As of now, less than 25 GFR, we are not using them. In India, less than 30 after Credence. And after Dapper-Ckd, that GFR cutoff has been brought down to 25. Those patients who are hypotensive, volume depleted, type 1 diabetics, or sick patients should not use. Otherwise, the drug, a very good drug, gets a bad name. You should use the correct drug rightly. So these are the sick day rules, as we have for metformin, as we have for RAS blockade. These are sick day rules for SGLT2 Dapagliflozin. So, ladies and gentlemen, I conclude with this slide. From a cardiovascular perspective, these drugs are very effective, be it a diabetic patient or a non-diabetic patient. And the same goes for renal outcomes. And that's why nephrologist is now a part of the discussion. There is a big beneficial effect of SGLT2 inhibitors across all levels of eGFR. And all diabetics, ladies and gentlemen, remember, in your clinic, when you are writing a prescription, creatinine, calculate the GFR on your smartphone. And if albuminuria is there or GFR is low, make sure that this drug is a part of your prescription. Thank you, ladies and gentlemen. This is our dialysis unit full of patients on dialysis. Most of them are diabetic patients. This is our transplant, 650 transplants. Many of them are diabetic patients. Remember, all these are major things and can be prevented to a certain extent. Prevention is always better than cure. And SGLT2 drugs here are here. The drugs are here for us to enable our patients to continue a long life without dialysis. Thank you for a patient hearing.
Thank you, Manisha. Now we have time for discussion. We may extend the discussion by another 5 minutes so that we can have at least 10 to 15 minutes of discussion. So let me summarize one by one and people can interject. That if you have a heart failure, diabetic or non-diabetic, also think of Dapper group. Dapper group may be SGLT2 inhibitor. I'm going to use it as the word Dapper group of drugs. Like we have Viagra group of drugs, where we have sildenafil, tadalafil. So similarly, I'm saying Dapper group of drugs. So if you have a heart failure with or without diabetes, use Dapper group of drugs. Sujoy and Dr. Hazra, is it right? Dr. Hazra? Your voice is not coming.
Ladies and gentlemen, sir, once in a day dapagliflozin should be standard of care because it's not that it is cheap and it has got tremendous data to support, especially in heart failure. And it has one benefit which is not seen in reduced ejection fraction with SGLT2, may not be in this particular trial, Emperor reduced, but Dapper-HF has shown that it reduced cardiovascular death. And though empagliflozin has shown its reduction of cardiovascular death in EMPA-REG, canagliflozin in Credence, Dapper in Dapper-HF, so all has been shown that it prevents death, and all has shown that it prevents heart failure, irrespective of the stages. So dapagliflozin should be standard of care.
So one question comes is that if you have a heart failure, where you have a reduced heart failure, a systolic heart failure, or ejection fraction is low, where your doctor says that you are at high risk of sudden cardiac death, and if you are at that particular risk, also ask your doctor why you have not put me on Dapper. That's one question for the public. And if you are a GP, ask yourself that why my consultant has not given Dapper to him. That's one. Number two, if you have a patient with albuminuria, and if it is more than 300 milligram per day, and you have a severe macroalbuminuria, and in that particular condition, if you are looking for a group of drug, you have a Dapper with you. Manisha.
Yes. So, very rightly said, sir. As I said, these drugs are underused. So, first thing is all diabetic patients or even non-diabetic patients for that matter, whenever we are following up as a physician or a general practitioner, we should do albumin as well as calculate the GFR. It's very easy with the smartphone. And those who have albuminuria or low GFR, these drugs should be a part of the prescription. Ethically, scientifically, they should be a part of the prescription. And
So,
Dapper, for non-diabetic CKD, we have evidence with Dapagliflozin.
So Sujoy, when it comes to diabetes, you need two minimum drugs. One is, up till now, we used to say the essential drug is ACE. You give Ramipril or whatever you want. That all diabetics should receive a nephroprotection by giving them ACE. And now we are talking about that Dapper group of drugs also becomes an essential part of a basket when you are looking for a management of diabetes. Sujoy.
I think one of the things that we've got to understand at this point of time, that we've conventionally thought of metformin as the first line drug of diabetes. Probably with time that will change, and already the European Cardiological Society has made that statement, and SGLT2 group of drugs has come up way top of the algorithm of management of diabetes and hyperglycemia. That's
So I'll
predominantly because
go ahead.
of the ancillary benefits of the drug apart from glucose lowering benefit. So unless and until there is a compelling contraindication for this group of drugs, I think this group of drugs is going to be probably be used even in a greater spectrum in patients with type 2 diabetes.
So all three of us, all four of us are ignoring one action of SGLT2 inhibitor, and that is that it is also an inhibitor of NLRP3 inflammasome, which is an antioxidant. It reduces reactive oxygen species induced NLRP inflammation. It reduces CRP. It reduces IL-1 beta. It reduces IL-6. It reduces TNF alpha, by which it reduces C-reactive protein, by which it reduces atherosclerosis. And if I reduce my C-reactive protein, it will reduce my renal inflammation, therefore it will reduce my albuminuria. It will reduce my myocardial stress, therefore it will improve ejection fraction. And it will reduce my HbA1c by 1. And I know that HbA1c, if it is raised by 1, there is 20% increase in CRP. So it will ultimately, why didn't we use SGLT2 inhibitor during COVID-19? Because COVID-19 pyroptosis is nothing but NLRP3 inflammasome induced cytokine crisis. What was, because somebody said initially, don't give SGLT2 inhibitor in COVID, it can precipitate DKA. But the same thing is true for metformin. On the contrary, metformin was said it is to be used in COVID-19. I'm little bit myself, because I have done extensive work in COVID. Why this drug, my personal intention is this drug would have reduced cytokine crisis compared to talking about precipitating a theoretical possibility of DKA. Anyone, all three of you, I would like to have your comments.
Right. If I could answer that, with regards to dapagliflozin, there is a trial called DARE 19 of the use of this drug, placebo-controlled, in patients with moderate COVID-19 infections. Our center was one of the centers of recruitment for COVID with, the use of this particular drug. The recruitment process has completed. The study results should be available in the month of March first week. And I agree with you that, I'm not asking physicians to go and use this drug at this point of time, but in terms of the concept that you spoke about, the concept is getting validated in a randomized double-blind clinical trial to show whether this is really beneficial or not.
Sujay, I only want to slightly disagree with you on one point, that it is a pandemic state. In a pandemic state, say, suppose there is a person who is dying and I want to do something to him. Am I going to ask for an evidence? He is dying. In a pandemic situation, logic also works. If you say there is a logic, you produce the evidence, look for anecdotal examples, and don't wait for, if you say preliminary data shows it is effective, it is effective. Let the randomized trial later on comes on. I feel on principle that Dapper is as bad as metformin or as good as metformin as far as COVID-19 is concerned. So I feel in COVID-19, in a mild to moderate cases, I'm not talking about critical cases where DKA is maybe a possibility. Dapper should have been, because all endocrinologists from day one has been frightening that Dapper means you will get DKA, D for DKA. You will end up into a DKA, therefore don't use it, don't use it, don't use it. And with that fear, even cardiologists stopped writing it, even renal protection stopped writing it. We said, let the COVID era be over. What about you, Hazra? What do you want to speak about? Do you think that it was over-restricted. Dapa was over-restricted during COVID era. It should not have been so much fear about using Dapa in COVID era. Sujay will give us the evidence in March, but as on today, with the logic, what is the answer?
Yeah, I fully agree with you that lack of evidence is not the evidence of lack of evidence. Sometimes if it is not there, it's not there, but it is quite sometimes intuitive and logical and provocative to use the same drug which has been tested and gone through the test of time in thousands and thousands of patients. And in viral infection, if it is not sepsis, if it is not overwhelming sepsis, bacterial sepsis, if he is not in shock, we have used dapagliflozins, and we are quite florid, avid user of dapagliflozins in acute situations, except sepsis, especially in acute heart failure, post-MI, post-angioplasty, post-primary angioplasty, post-large angioedema, without shocks. So I fully agree with you that it has got some anti-inflammatory actions, as somebody has mentioned, the ROS production. As I said, it is a housemaid which cleans the house. That inflammatory milieu, it cleans, it improves the mitochondrial functions by removing the toxic things, the anti-metabolite, so on and so forth. We are still learning. Over to you, sir.
Thank you. Manisha, you want to add on this? And then after this, I will come back to Sujay again. So to all three of you to give 5 points each as the take-home message. First, that we have underused this in COVID. Manisha.
Yeah, I guess so. I fully agree with what statements you've made, Dr. Agarwal. But because it has been a relatively new drug, that apprehension was there. And Dr. Sujay has nicely pointed out that what you have said regarding that inhibition of NLRP3 inflammasome, which I was showing in this slide, that it's a smart drug because it inhibits the renal work, the inflammation as well. So that's very well proven by physiology. And as Dr. Sujay was telling, we will have a randomized control trial to support that as well, the day 19. Absolutely. I fully agree. We have underused the drug.
So for those who are watching this program, there are two receptors in a cell, that is TLR and NLR. TLR is toll-like receptor. NLR is not like receptor. So when you enter a cell, you have to pay toll. Therefore, TLR comes in, and there comes it. And then when you enter the cell, and by not paying the toll, then you are given a heavy fine. And therefore, NLR takes over, converted into an inflammasome, and apoptosis is converted into pyroptosis, and that causes cytokine crisis. Coming back to Sujay again, can we have the 5 take-home messages?
I think the first thing is that this is probably one of the best groups of drugs that have been discovered in recent times. What started off as an anti-diabetic agent is now a drug which is useful for organ protection and prevention of complications related to the heart as well as the kidneys. But having said that, in patients with type 2 diabetes, please do not forget that you have to reach glycemic targets as well. So reach glycemic targets. In that, wherever possible, try and use the SGLT2 group of drugs. And now we have evidence beyond diabetes that this group of drugs might be useful when used even in non-diabetic individuals for heart protection and kidney protection. That would be my take home.
Thank you, Sujay. And then coming back to Dr. Hazra.
Yeah, I think it's a day one drug for all diabetics. Forget the type 1. Up to 25 ml of GFR. Take care of your kidney on the very first day and ask your doctor, discuss with your doctor what are the benefits you're going to get on the very first day, very first week, very first month, very first year of your life. And definitely it will add extra life to your years and years to your life. Only during sick day you have to avoid, and infection is the main contraindications. But if you bring down your sugar by diet, lifestyle modification, initial insulin, initial DPP4, or then you start the drug, it doesn't harm much, but definitely glycosuria amount will be less. And if you take care of your hygiene, the infections, inhibitions, and recurrent infection will be lowered. It will suit you nicely.
Manisha?
So 5 messages are CKD is common, first message. Second is all diabetic patients in your clinic from day 1 itself screen for renal functions, creatinine and albumin, and do it annually after that. The next message is if albumin is positive and if the GFR is low, add SGLT2 inhibitor in all diabetic patients. As of now, the guidelines say lifestyle, metformin, and SGLT2. But as Dr. Ghosh was telling, it's already being now recommended that they can be used first line without metformin as well. And the last is in non-diabetic patients also, up to the level of GFR of 25, Dapagliflozin can be used, but still that 5th point has to be approved by DCGI. The drug is in the process for being used and approved for Dapper CKD for non-diabetic CKD patients.
So for non-diabetic CKD, as on today, it's an off-label use. Therefore, it is always better to tell the patient that this is the off-label. When you are using any off-label drug, that doesn't mean that you can't use it. Off-label drugs have to be used with the informed consent as a shared decision between you and your patient. And when the patient is coming to you, it is taken as an implied consent that whatever you are writing is okay. So you can write down.
As you said, a consent we are taking now. Yeah.
So remember that the Dapig drug is also available as a 5 and 10 milligram tablet separately. It is also available with metformin. It is also available with sexagliptin and 5 milligram, 10 milligram. So these drugs are easily available. All of you who are watching this program, if you are aware of this, you are well versed, you are writing this, well, it was a revision for you. But those who have never used this drug, kindly see this program again and again. The link will be sent to you by Sun Pharma. Watch this program again and again. Get used to this particular drug. May end up into a wonder drug for D for Dapper, D for diabetes. Thank you, Sujoy. Thank you, Dr. Hazra, and thank you, Manisha, to be here with us. And I just like to see if there are some important questions. I just want to pick up one question which has come from the audience, and that is, why are you taking a risk of sugar? Why are you taking a risk for UTI? And I only want to say about that answer is that every drug has some side effect. Therefore, don't worry about the side effect, manage them and anticipate them. So no drug will be safe, even water is not safe, even air is not safe, even the food you are eating is not safe. When we have food safety, similarly, there are drug safety. As a doctor, you need to know the contraindication, you need to know how to manage your patients. Remember, a diabetic patient is going to be on multiple drugs, so you need to know all the interactions. That's all for today. We will be back with one more seminar. Keep watching us, keep waiting for us, and we may come back with many more such interactions with you. Thank you, everybody.
Thank you.
Namaskar.
Thank you, sir. Thank you. Pleasure. Thank you.